talk, and then we'll take questions. For the third talk, we have Dr. Ashish. Dr. Ashish is a senior consultant in Gangaram Hospital, New Delhi. He has done his DM from SGPGI, and he was my colleague there. And since then, I have seen him grow in the ranks of academics. He has got a number of published papers, and in fact, he is one of the co-authors of the HCC guidelines by the Indian National Society. And I'm sure he is the best person to present this topic. And over to Dr. Ashish.
Thank you, Dr. Piyush. Are my slides visible? My slides are visible?
Yes, they are visible.
Okay. Thank you, Dr. Piyush, and thank you, Dr. Anuj Maheshwari, for inviting me to talk about liver cancer in this American College of Physicians India chapter. So I would give a brief overview of liver cancer approach to the management. But before I go on the approach, I would like to present few cases. So this is the first case, a 47-year-old lady who presents with hematemesis and melena. And on examination, there was nothing positive except some anemia and splenomegaly. And on investigation, the endoscopy showed large esophageal varices. Her HBsAg hepatitis B viral marker was positive, and ultrasonography showed shrunken nodular liver with a dilated portal vein. So the diagnosis of cirrhosis, which was hepatitis B virus related, was made, and since her liver function test and she did not have ascites, liver function tests were normal, so she was labeled as child A cirrhosis. So she was given treatment in the form of endoscopic variceal ligation and antiviral treatment, and with this she got better, and then she was lost to follow-up. Subsequently, about 3 years later, she again presented, and this time she presented with pain abdomen, jaundice, and tense ascites. And at this time, ultrasound showed, apart from ascites, it showed 5 centimeter space occupying lesion in the right lobe of liver. Her alpha fetoprotein, the tumor marker for the liver cancer, was 8,700. The normal values are less than 40. And then this time the diagnosis was made as hepatocellular carcinoma, along with cirrhosis, which she already had, hepatitis B virus related, and now her condition is that she's child C cirrhosis with advanced liver disease. Coming to the second case, this is a 55-year-old male who's a chronic alcoholic, and now he presents with abdominal distension and pedal edema along with jaundice, and he has been drinking till very recently. On examination, there's icterus and ascites. And on investigation, ultrasound shows nodular liver ascites. Liver function shows bilirubin of 4.5, low albumin level. And the diagnosis of cirrhosis, which is alcohol related, is made. And since he has already jaundice as well as ascites, so it's a decompensated cirrhosis, child C status. So he's advised abstinence, and he's given diuretic and therapy and other supportive measures. And again, he now comes again 1 year later, and then he presents with tense ascites, jaundice, and this time his ultrasound shows multiple space occupying lesions in both the lobes of the liver. Alpha fetoprotein is normal, although, but we order a triple phase CT scan abdomen, which show that all the space occupying lesions enhance in the arterial phase, and there's a washout in the venous phase, and so a diagnosis of hepatocellular carcinoma in the background of cirrhosis, child C status is made again. Coming to the third case is of 65-year-old male, obese, diabetic for 8 years, and he just presents with loss of appetite and a dragging pain in the left upper quadrant in the abdomen. On investigations, his anti-HCV is positive, and his hepatitis C viral load is 10 to the power 7 international units. His alpha fetoprotein is normal. Ultrasound shows irregular nodular liver along with a space occupying lesion about 9 centimeter. And again, we order a triple phase CT scan, which shows the SOL, which enhance in arterial phase and wash out in venous phase. Again, a diagnosis of hepatocellular carcinoma with the background of cirrhosis, but this time a child A cirrhosis is made. So what is common in all the 3 cases? So all the 3 patients had underlying cirrhosis. All the patients present with HCC, which is fairly at advanced stage. The first two patients present with HCC, liver cancer, along with advanced liver disease. The third patient presents with a large tumor, which is also beyond curative therapy. So all the three present with HCC at an advanced stage. And the tumor markers AFP is not very reliable because in 2 of the cases it was normal, and in only 1 it was high. So who gets hepatocellular carcinoma? So what are the risk factors for hepatocellular carcinoma? The most important risk factor for hepatocellular carcinoma or the liver cancer is the cirrhosis of the liver. So cirrhosis can be of any etiology. It could be due to hepatitis B virus related. It could be hepatitis C related. It could be a non-alcoholic steatohepatitis, NASH, or it could be alcohol, or it could be of any other etiology. It could be Budd-Chiari syndrome. It could be autoimmune liver disease, or it could be any etiology. But if there is cirrhosis, then this patient is definitely a risk factor for having a hepatocellular carcinoma. Along with cirrhosis, there are certain contributory factors. For example, if the patient has coexistent diabetes, or if he's consuming tobacco, if he's smoking, or if he's having aflatoxin, then all these conditions also contribute to the development of hepatocellular carcinoma. But the most important risk factor remains as cirrhosis of the liver. This was a recent study which was published from PGI Chandigarh. It was a very large study of about 800 patients, and this gives a very good overview of what kind of patients present with hepatocellular carcinoma. So this was a study of about 800 HCC patients, and what we see that in about 86% of patients there is underlying cirrhosis of the liver, so which is a most important risk factor. The most common age of presentation is around the 7th decade. That means age between 60 to 65 or above 50 years of age. Most of these patients are male, so it is a male predominant disease. And about 1/4 of these patients already have diabetes, which is contributory factors. The symptoms are not very specific. Some patients may present with loss of weight or appetite. Some patients present with abdominal pain. Some patients present with jaundice. But one important thing is that most patients present at late stage. We commonly do the staging according to the Barcelona staging, and the stage A, only 22% patients had presented in stage A, which has got curative therapy possible. And about 80% of the patients present late in the stages B, C, or D. So as I told you, the most important staging system of the hepatocellular carcinoma is Barcelona staging or BCLC staging. And it takes into account 3 things. One is the liver status. The other thing is tumor status. And third is the performance status. So if the liver status is child A or child B and child C, accordingly, the staging is done. Tumor stage, depending on the number and size of tumor, and performance status, if he's very looks healthy and is moving all around, then his performance status is good. Or if he's bedridden and if he's confined to a wheelchair, then he has bad performance status. So depending on these, there are 4 stages are there, 5 stages are there. One is very early stage or stage 0. Early stage, that is stage A. Intermediate stage or stage B. C is advanced stage, and D is the terminal stage. And depending on these stages, the survival is also there. In very early stages, the 5-year survival may be more than 70%. In early stages, it is 40 to 70%. And in the intermediate stage, it is about 19-20 months. In advanced stage, it is about less than 1 year, and in terminal stage is less than 3 months. And depending on these stages, the treatment also depends. For in very early stage or in early stage, curative treatment for the liver cancer is available. But for intermediate stage, advanced stage, and terminal stage, only palliative treatment is possible and curative treatment is not possible. So we have 2 facts now. The first fact is what I presented is that cirrhosis is a predisposing condition for development of HCC. The second fact is that early detection of HCC, that is in stage A, has the better chance of cure and survival. Like in any cancer, if it is detected early, it has better chances of survival. So if we combine these two factors, then there is a definite role of surveillance. So if the patient of cirrhosis is there, if we are following these patients, and if we can do screening in these patients, then we can definitely detect early detection of liver cancer in these patients. So almost all the liver societies recommend that surveillance is an important part. HCC surveillance in patients with cirrhosis can detect early tumors that are potentially amenable to curative treatment. And how we should do surveillance, and it is recommended that we should do 6 monthly ultrasound abdomen by experienced personnel who is experienced in detecting liver tumors, which is recommended at every 6 months. And alpha fetoprotein, the tumor marker, can be added, but alone AFP is not a reliable marker for surveillance. So 6 monthly ultrasound along with alpha fetoprotein is the best modality for surveillance in these patients. So when we do ultrasound of a cirrhotic liver, what we see is that there's a rough liver margin, there could be ascites, and there's a heterogeneous enhancement of the liver, cirrhotic liver tissue. But when there is a space occupying lesion, it is hypoechoic lesion which is seen. So whenever space occupying lesion is seen in on ultrasound in any cirrhotic liver, then the differential diagnosis would, the number one would be HCC, but it could also be regenerating nodule, it could be dysplastic nodule, focal fatty infiltration, adenoma, hemangioma, metastasis, cholangiocarcinoma. So we have to rule out all these conditions whenever we detect a space occupying lesion in a cirrhotic liver. So how do we do that? Do we do a FNAC or do we do a CT scan? The answer is that the best modality for detecting liver cancer in a cirrhotic liver is a CT scan. So what we do is a triple phase CT scan of the abdomen, which is the investigation of choice for diagnosis of HCC in a cirrhotic liver. The characteristic finding in triple phase CT scan is enhancement of the nodule in the arterial phase and washout in the portovenous phase. So what are these? I would like to tell you now. So as we all know, the liver's blood supply is from 80% from the portal vein and 20% is from the hepatic artery. So whenever we do a CT scan in a normal liver, when we inject contrast, the liver will enhance whenever the contrast will reach through portal vein. So it will enhance in the portal venous phase. But what happens when there is a hepatocellular carcinoma, HCC? HCC blood supply is predominantly from the hepatic artery. So this, because of this factor, so whenever we do a contrast enhanced CT scan in a cirrhotic liver with an HCC, the HCC will enhance during the arterial phase, the early phase. And during the portal venous phase, when the rest of the liver is enhancing, that time it will not enhance. So in relatively, it will appear as if the enhancement has washed out. So this the phases of triple phase CT scan. This is the first phase, that is non-contrast CT scan, where none of the lesions are enhancing. But when we give contrast through in the arterial phase, the hepatocellular carcinoma tumors are enhancing, that is in the arterial phase. But once the contrast reaches through portal vein, the rest of the liver enhances, but now the contrast is not in the arterial phase, so this appears as washout, and in the late phase all becomes isodense. So this is called triple phase CT scan abdomen, and for detection of HCC, this is the best modality in patients of cirrhosis. So again, this is in the arterial phase, it is enhancing. In portal venous phase, it is washed out, and in equilibrium phase, all are become equal. The HCC is characteristic lesions because it will show enhancement and washout in the enhancement in the arterial phase and washout in the portal venous phase. All other differential diagnosis which I mentioned, like adenoma, hemangioma, metastasis, cyst, will not have this characteristic feature on the CT scan. Now, once we have diagnosed hepatocellular carcinoma, we do the staging. As I already told you, we do the staging. The commonly done staging is through Barcelona Clinic liver cancer staging, or BCLC staging. It takes into account three things: liver function, performance status, and tumor burden, as I already told you. So Based on the BCLC staging, the survival also depends. In very early stage or early stage, when the tumor is small and performance status is good and liver functions are good, that survival is more than 5 years. But as the staging advances, the survival deteriorates. And the treatment is, so this staging not only tells about survival, it also dictates how we should treat these patients. So the treatment of liver cancer is actually multimodality, and depending on the stage, we give the treatment. For very early stage and early stage, the treatment of choice are ablation, where we ablate the tumor, or resection, we do surgical resection of the tumor, or we do liver transplantation. For the intermediate stage, we do a procedure which is called as transarterial chemoembolization. I'll come to detail about it. And for advanced stage, we give systemic chemotherapy, or we also do transarterial radioembolization. And for terminal stage cancer, we only can give best supportive care, because none of these treatments are tolerated by these patients. So coming to the first type of treatment, which is done in early stage or very early stage, that is the curative. One is ablation, resection, and liver transplantation. So what is ablation? Ablation can be done by two methods, either by chemical method or by energy method. By chemical method, we inject either ethanol into the liver tumor percutaneously, or we also may inject acetic acid. So this is we ablate the tumor. This is done for a small tumor, 2 to 3 centimeter in size. But nowadays, this has been replaced by energy mediated ablative method, most commonly done through radio frequency ablation, where heat is generated inside the tumor, or microwave ablation, or even cryo ablation, where cold therapy is given. So how is ablation done? So for ablation, we percutaneously we introduce ablative needle. This is a radio frequency ablative needle, which is introduced percutaneously through the liver, and it has got multiple probes, and these probes are released, and these generate radio frequency, which leads to heating of the tumor, and then it leads to charring or the burning of the tumor. And then the track is also ablated, so that the tumor track, there's no tumor track seedling. So this is ablation. But ablation has to be done only in patients which have got small tumor and which are located at a favorable location in the liver. The next modality which can be done in these patients, if the tumor is small, that is resection, that is surgical resection. So we can do a wedge resection of the tumor if it is located in the periphery. We can do a sectional resection. We can do even remove half of the liver, that is left hepatectomy, or a segment of the liver. But whenever we do resection, we must ensure that the residual liver tissue is adequate to take over the function, and there is no portal hypertension. So we have to very carefully choose these patients, that they don't have clinically significant portal hypertension, they are not bleeders, they don't have significant varices, and their portal pressure is not very high, and their tumor is small, so that the residual liver tissue is healthy enough and which can take over the function after the resection. So this is the resection. And the third important curative treatment is the liver transplantation. And the most commonly used criteria for liver transplantation, that means when do we subject these patients for liver transplantation, is called Milan's criteria. It was developed in the city of Milan. The Milan's criteria states that either the tumor is a single tumor in the liver, which is not more than 5 centimeters, or if there are multiple tumors, they are not more than 3 tumors, and none of these tumors are more than 3 centimeters. So if the patient satisfies this Milan criteria, and apart from this tumor size and number, there should be absence of vascular invasion, as well as there should not be any extrahepatic spread. So portal vein or hepatic vein should not be involved, and the tumor should be either single, less than 5 centimeters, or it should, if they are multiple, they should be less than 3 and less than 3 centimeters in size. So if these criteria are met, then the liver transplantation is hugely successful, and these patients have got excellent 70-80% or 5-year survival rate. But sometimes the Milan's criteria is not met, and the tumors numbers are higher than which is prescribed by Milan's criteria. Then we may go ahead with the liver transplantation. But as the tumor number or as the tumor size progresses, thus similarly the success rate or the long-term survival will decrease. So these three, ablation, dissection, and liver transplantation, are the curative treatment for the liver cancer, HCC. Now coming to the when the tumor is of intermediate stage as per BCLC staging, and then the curative treatment is not possible. So what is the treatment? That the best treatment in this stage is transarterial chemoembolization, or TACE. So what is TACE? So in TACE procedure, we try, it's a kind of angiography procedure. We try to reach the liver tumor from the femoral artery. We reach the aorta, and from there we reach the hepatic artery, and we try to reach super selectively reach the tumor tissue. And there we inject chemotherapeutic agent, as well as we embolize the hepatic artery, so that due to these chemotherapeutic agents like doxorubicin, epirubicin, which locally act on the tumor and they kill the tumor. And we also embolize the hepatic artery so that there is a ischemic necrosis of the tumor tissue. So this was the TACE procedure, which is done for intermediate stage. What about advanced stage? Advanced stage is said when there is either extrahepatic spread of the tumor, or the tumor is very large, or there is macrovascular invasion, that means portal vein or hepatic veins are involved. Then the only treatment possible is either systemic therapy or sometimes transarterial radioembolization. So transarterial radioembolization is similar to transarterial chemoembolization, but here we are injecting the radio labeled radioisotopes, usually yttrium-90, which give a local radiotherapy to the tumor. The other thing which we can do is systemic chemotherapy. And currently, the first line systemic therapy is atezolizumab and bevacizumab combination. The other drugs are lenvatinib and sorafenib. So atezolizumab is a monoclonal antibody. It is an immune checkpoint inhibitor. So immune checkpoints are recently discovered modality of treatment for cancers, where because of immune checkpoint, these the body is not able to mount an immune response to tumor, and so these monoclonal antibodies or immune checkpoint inhibitors are able to block these checkpoints. So atezolizumab is the immune checkpoint inhibitor, and it is combined with bevacizumab, which is an angiogenesis inhibitor or vascular endothelial growth factor inhibitor, and the combination of these two are given, which is given every 3 weeks. And recently in 2020, this trial was published, and which showed that with atezolizumab and bevacizumab combination, the survival was much better than the previously used chemotherapy, that is sorafenib. With this, there was a better survival, about 3 to 4 months of progression-free survival. Other therapies like lenvatinib and sorafenib have been there for now many years, especially sorafenib, more than a decade. Since 2007, it has been launched, and it has changed the HCC tumor treatment chemotherapy. With these with these chemotherapeutic agents, that means targeted therapy as well as immune checkpoint inhibitors, the median survival is now gradually increasing in these patients, since these systemic therapy is given to patients who have already advanced tumor, and now the survival is to the tune of 16-17 months, or even up to 2 years. What about second line and third line systemic therapy? Once the patient has received atezolizumab, bevacizumab combination, and if he has not responded, then he can be switched over to sorafenib or lenvatinib. If there's side effects, or if there's no response to these also, then there are multiple third line agents which can be switched over, and which can help in prolonging the survival of these patients. So the take-home message for today's talk is that most HCCs occur in patients who already have cirrhosis. Hence, all patients of cirrhosis must undergo a 6-monthly ultrasound surveillance to detect any HCC development. And if this would help in early detection of liver cancer, and so that a curative treatment is possible. Any space-occupying lesion detected on ultrasound must be in a patient of cirrhosis, must be followed up with a triple phase CT scan for confirmation of diagnosis of HCC. The FNAC is usually not required for confirmation in a patient of cirrhosis. And alpha fetoprotein may or may not be elevated. And for the treatment, it depends on the staging. The most commonly used staging is Barcelona clinic liver cancer staging, and a multimodality treatment is given depending on the stage. For usually other cancers, we only have chemotherapy, radiotherapy, and surgery. But for liver cancer, we also have liver transplantation. We also have ablative therapy. We also have transarterial chemoembolization. We also have transarterial radiotherapy, and now even stereotactic radiotherapy, or SBRT, is also coming up. So we have a multimodality treatment, but the most important thing is for early detection of these tumors. Thank you for your patient hearing.